it's a low resistance type of activity other than your body weight. Now you can always make it a more resistive activity by adding a weighted vest, by putting a bar on your back, holding some kettlebells, whatever it may be. But if you don't want to do that and you just want to put the blood flow restriction cuffs on, I think it's another very, very good tool to have in your toolbox.
Hey everybody, Doug Adams here with Run DNA Podcast, and happy to have Scott Greenberg back on the show here. I think we're kind of noticing a theme. We were just talking about it of maybe like 5 things with Scott and Doug here. Although if you listen to our last one, it turned into 11 things, which is very typical of Scott and I. But our goal with this is really just to provide some quick, concrete tips and tricks that you can use when working with runners. If you're a runner yourself, we want to even include that. So our thought today was, on the last episode, Scott said his least favorite thing to treat was medial tibial stress syndrome. So let's go into that and just make it fun for Scott and start talking about that. Maybe say like 5 things that should be in every plan of care for medial tibial stress syndrome, and 3 things that a runner can do themselves. So if you're a runner listening, there's still going to be a lot of value in here. And if you're a running specialist, a lot of value too. So Scott, I know you're just thrilled to be going over medial tibial stress syndrome.
Like I was telling you before, I couldn't sleep last night. I was so excited to talk about this today.
Yes. Yeah. I mean, it's one of those things, but it's the incidence of it is like, I think it was just looking up some stuff before. It's like 20 to 35% of runners experience this medial tibial stress syndrome.
Definitely a common thing. And you definitely need to have some tools in your tool bag to help combat this, because you're going to see it.
And one of the things about this, I'm sure we'll get into this as we go in too, it's almost entirely preventable. Like, that's the bear. And I don't know if that's why you don't like to, but there are things that you can really do that where, at least if it's not preventable, maybe you can really make it a non-issue type thing, where you're not going to, you're going to have this time to time eventually, but it's something that I think if you learn some key steps and tricks and you kind of recognize it early enough, you can make it a non-event, at least there. That's my experience with it too. I think a lot of it's preventable.
I think a lot of running injuries are preventable. Like, once you start feeling something go wrong, instead of pushing through, kind of pull the brakes back.
Yeah.
And kind of, I always say, live to run another day. I think that is a super, super important thing to emphasize with our runners. We always talk about your capacity one day is not the same as your capacity another day. Right. And if for whatever reason you're out there and you're not feeling good and that shin pain kind of starts, or whatever pain it may be, just kind of pulling the brakes down and kind of packing it in for the day, if you can, I think is going to pay dividends in terms of A, do you even have a problem moving forward, or B, how bad that problem is going to be? Because you can make a small problem very, very large by just pushing through. Again, if you have a race, you're in the middle of a race and you have to finish the marathon, whatever it may be, but that's fine. But as long as you're willing to pay the consequences at the end, that's fine. But if you're, living to run another day is, like I said, a statement I always say. And I think we can prevent a lot of these things just by being smart about how we feel.
Yeah, I think that's a great way to put it. Live to run another day. And that's even in the first episode of this podcast, the whole thing was, let's take the stigma away having a running injury and just say it's part of the sport. And if we acknowledge it a lot sooner, maybe we'll do something about it. And I think this is a great diagnosis or injury type that we can really dive full in on that and say, hey, listen, if you're having some shin pain, just own it. And let's take care of it pretty quickly. So, all right, if you're not familiar what medial tibial stress syndrome is, it's a lot of times called shin splints or medial shin splints. So pain on the inside of your shin a lot of times there. And this is an early stage of a bone stress injury. I think we talk about, you were just saying live to run another day, and you say, hey, you can make things a lot worse. This is one of those injuries that is on the spectrum of bony injuries that, if left unchecked, can really turn into it here. But the way that it happens is that our bones are really good at absorbing axial loads or compressive forces. They're not so good when you pull on them. They're pretty brittle, actually. And what we we see here is that there's this structure called the periosteum that lines the bone, it's connective tissue, and it overlaps with a couple tendons, the soleus, tibialis posterior, flexor digitorum longus. Those overlap, and when you have tension in those muscles, either from overworking them or just some more chronic tension, it pulls on that periosteum. And then you remember this from PT school, the Sharpey's fibers.
Yes.
Yeah, Sharpey's fibers. I like zoned in on that on PT school for some reason. But the periosteum gets tight, and then its attachment to the bone pulls on it, and it causes this little micro trauma to the bone. And then these fissures aren't fractures at that point. It's just stress and maybe a little edema or things like that make the bone not as strong of a quality. And then when you do get the axial compression or the impact of running, then the bone is weakened and it can progress. Now, the medial tibial stress syndrome is more on that like periosteum irritation, and it's more local to there. There's not always bony findings with this there. You might see some edema in the area, but it's not necessarily in the bone at this point here. But left unchecked, it definitely can turn into stress reactions or stress fractures, as we see with it here.
What I usually also use as the defining factor as to whether it's a stress reaction / fracture or more of a medial tibial stress syndrome type of situation is the length of tenderness to palpation. So you tend to see the stress fractures and reactions tend to be a lot more isolated to a very localized point, whereas the more of the shin splints, tibial stress syndrome type of issues tend to move up and down the shaft in a more diverse kind of region. So less local, more diverse with the tibial stress syndrome situations, and more localized with the stress reaction, stress fracture.
The other thing, I'm glad you brought that up because I didn't kind of prepare that. But another thing I always look for when kind of diagnosing this, not just the palpation that you talked about, which you can do on yourself, just kind of palpate the inside middle third of your shin at home. And if you're tender to touch there's an element of medial tibial stress syndrome. But I think pain with walking and pain at night are the two big things I use to differentiate between somebody that is having closer to a bone reaction versus more of this medial tibial stress syndrome. That's a big thing that I find. If you're having pain at night, that's definitely alarming. And if the pain is better or is still bothering you with walking, I think you've progressed it a little too far. Yeah. This is something I also, along the same lines, I see it in the early stages. I think the trick is it warms up a bit and you'll start to feel better as you go. And that's another way to kind of stage it too, is if it does warm up, you're okay. We like to follow the soreness rules, that if it's sore for more than 24 hours after the run, even if it warmed up during the run, you probably did too much. But if it warms up and gets better as you run, that's better. I'm not talking like 4 or 5 miles warms up, 4 or 5 minutes warms up thing. So that's another thing, just if you're thinking about and either educating your patients or educating yourself about whether you have this, those are things that I look out for too. Yeah,
I'm on board.
Yep. Yeah. All right. That's kind of like diagnosis, method of injury, and what it is here. So let's dive into this treatment strategies. All right. So the way we did this last time was fun. Think about all right, what's the number one thing here that you would say is a treatment strategy, right? And this doesn't have to be anything specific. What's your number one? And then I'll share mine.
Modify your activity and training load.
I agree on that. And I went back and forth between that being number one or number two. I put it as number two because I want to first identify why that individual had it. Like, why is that the weak link in the chain? Okay, so we know that a lot of times it is related to training load errors, right? And training load errors, meaning doing too much, too fast, or too frequently, accounts for about 60% of running injuries. But in my mind, I see this as such a repeat injury that people get time and time again because one, I 100% agree the importance of load modification, but I also think that people keep getting this because they're not addressing the underlying cause, and they're not figuring out why that person is having, or why you're having these injuries in the first place.
So I agree with that, but I'm gonna throw it back at you. I'm gonna stay with my point. Whereas I think that would be number two, because I think these injuries are so multifactorial in nature, and there's so many different reasons why they can occur that if you may not be right, and if you're just waiting to get that before and try to make that decision before you modify your activity, you're going to be down the same rabbit hole. So I think modifying your activity first, and then diving into trying to identify, okay, now that we got things kind of under control, we're not pushing beyond where we need to, we're in a safe zone. Let's figure out what you were doing that was maybe contributing to this. That's my feeling. Just because, again, there are so many factors, and we rarely know in running in general. We rarely know. We have some good guesses, right? We're smart. We have some good guesses. We have a lot of anecdotal evidence, but there's very few things that really kind of lead us down the rabbit hole of, yes, we definitively know that this is the reason that caused that. Again, tissue capacity. What is the tissue capacity at a given time? What were your stresses? What was your, how much walking did you do throughout the day on that given day following, preceding the run that maybe caused this? So again, there's just too many things for me to pigeonhole, like identifying the root cause immediately before you start diving into, let's back off, let's cut it back a little bit, and let's reevaluate as my framework.
I see that as a point. I mean, I validate that and agree. And obviously, like, in reality, these are probably both, number one, you're going to do both on the first time you see a patient or things like that. But I see the point that, like, pain can change movement, right? We do know that. So you want to make sure, now I would argue, like, hey, every session you should be doing evaluation and test retest, and I'm sure you're the same way. Like, we should be looking at that. We should be really, like, individualizing it. So I don't know. We can let the listeners kind of say what they think, number one, or like, but I think you're probably doing both of these at the same time, right? Like, on the first time somebody sees me, I'm going to modify load, but I'm also going to start understanding what's the biggest contributing factor to that. And that might change during the course of the treatment. You might be like, oh yeah, your ankle's super stiff. You have like no tailor joint mobility, but maybe that happened because they're in pain and they're guarding. Right. So you can say you need to do ankle mobility
a lot of times, right? So they have limited dorsiflexion, but why do they have limited dorsiflexion, right? Is it something up the chain that's preceding them to have limit? Is it that knee goes into too much valgus, which pushes their foot into into the abducted position, where they don't actually push into dorsiflexion? And yeah, exactly. So,
and you're torsioning and doing that. So yeah, this is where I'm a big proponent of the runner readiness assessment. I would do this on the first day. We're going to look and break down and understand, hey, like, I do see a lot of ankle mobility restrictions with this. I do see a lot of hip mobility and glute activation issues with this, and foot. I think that the foot is often asleep at best and maybe a little slow more commonly there. But I'll see that a lot on the runner readiness. So I think I think a general treatment approach, as always, for every injury is just find the personal thing that person needs, and realize that that's going to change over the course of the treatment potentially too. Mm-hmm. That don't just say like, oh, on the first visit, this person had ankle dorsiflexion limitations, and I'm just going to mold their ankle for 10 visits. Don't do something when it's better, and keep evaluating to see what the most important thing is. Mm-hmm. But all right, load modification. Let's go a little bit more into detail about that, right? So for me, one of my first thoughts is not all load modifications are created equal. And I think I'll say that because I think a lot of people will say load modifications, but there's more dangerous load than others. So what I mean by that is reducing the intensity is often my first thing, because you'll get a lot of resistance to reduce the frequency at which they run, and you have to still be an advocate to the patient for the patient. But I think that modifying intensity is often my first thing that I'll suggest, depending on the stage of it, right? Like if somebody's coming to me fairly early in the process, I'll say, hey, let's cut off speed work for the next little bit. Like cut the strides, cut the hill repeats, cut the track work. Let's try that first.
So the thing I'm going to say here is, Potentially, right? For me,
Right.
I'll say potentially, because I think sometimes if you cut the speed and the intensity, I find that most of these type of injuries occur as it relates to stance time, loading time,
Mm-hmm.
time in contact with the ground. So as we know, the slower we go, the more time we spend on the ground.
Right.
So if somebody is spending an excessively long amount of time on the ground, in a certain position, let's say, and this is where you got to start looking at things like rate of pronation, the amount of pronation,
Mm-hmm.
and if they're in a position for a prolonged period of time, that to me is problematic. So if they go through a rapid pronation phase, tibia internally rotates, and then they're still in contact with the ground, but there's nowhere else for their foot to move. Like they're planted, they're rotated, their knee has to go in. There's a lot of other compensatory things that have to occur due to that loading time. I think that sometimes can be made better by speeding them up a little bit. Now, granted, the forces are greater, in
Yep.
contact with the ground. So you've got to weigh the importance of the actual force contact, the impact with the actual torsional force, and see which one makes them feel better or worse. So those are things that I'm looking at, and you can kind of again, this is where you put your detective hat on and kind of say, okay, let's see what you look like, right?
Right.
So in both of our cases, I know we're very big into the gait modification, gait evaluation side of things. You know, doing your static assessment and looking at just general movement before getting them on the treadmill is important, but then seeing what they look like running, and again, looking at their posture when they load can be very, very telling as to what is happening to that tibia. I often say, in medial tibial stress injuries or stress fractures to the tibia, it's like a towel that gets wet and you want to wring it out, right? So what do you do when you wring it out? You take that towel and you twist it, right? And what does that do? That incredible amount of twisting force forces the water out of the towel. Well,
Yeah.
if you're creating that same twisting force due to prolonged loading in a certain posture, that can be problematic. So we've got to figure out how to avoid that and limit that or diminish that as much as possible.
So I agree with a lot of that, and I'll throw one counterpoint out, right? Rate of force production versus total force, because the body is good at handling a lot of force, but only so much in a given time. So the angular acceleration and velocity, something I actually look at a lot on the 3D, that's a way that I determine it, and to see if they're having excessive angular velocities and accelerations, because we know that the body can handle a lot of force in any given instance if it's applied at a rate that our body can absorb there. So
So I
having it,
agree with you, but for me, it's not so much the actual rate; it's what the rate does. So if they're pronating excessively quickly, then
yeah,
what happens? Then they're in a position where they can't move anymore out of that position because they've gotten to their endpoint more rapidly. So their foot is still in contact with the ground, but they've rapidly rotated. Now, again, I'm not worried about the rapid rotation. Let's take that out of it. Let's take the
yeah,
fact that they've just done this motion and now they're, if the same thing as a rapid motion with limited or decreased mobility. They have decreased mobility, but yet they're still in a stance phase for a prolonged period of time. They're going to be beating up a certain part of that tissue excessively long because they have nowhere else to go. So that's
yeah.
why I think joint mobilization and dorsiflexion mobility and those type of things are very helpful, is because they create more degrees of freedom for that joint to move.
Mhm. Yeah, it's a mitered hinge. We know that that's important. And we know that, like, this is directly out of one of our certified running gait analyst courses, right? Axial torsional loading. So
Yep.
compressing and twisting at the same time reduces the bone to 59% of its normal capacity,
Yep.
which is not enough to run downhill. So, I mean, I agree with those things. I just think the intensity, for the most part, I've done like tons of gait analysis where everyone always says, this is kind of like a soapbox of mine. Everyone's like, oh, well, my form will look so much better when I run faster. And guess what? It doesn't. It
Mm-hmm.
actually, like, it looks worse from like all those things you're saying about posture and body position, but they're just not on the ground long enough to feel some of the interaction.
I think most people's form improves if they run faster at their maximum speed, to me. So again, if they're still going faster, but yet they're still holding back, I think to me they're still not very natural in terms of their form. Like again, it's very, very hard in my opinion to sprint a
Yeah.
certain way.
Yeah.
And I think when we run at speeds slower than sprint speed, I think our body takes over and tries to find out the way that people deem is maybe most comfortable at that given time. And I don't necessarily always feel like that what's comfortable for them at a given time will be the same comfort level if you educate them on a different way to run. They just might not know any better.
Yeah, and we're a little on a soapbox, but I like it here. So, like, because we're obviously not advocating that people with medial tibial stress syndrome go sprint as hard as they can right now. That is not the goal. We're on a little tangent just to make sure we're coming back. But my finding is actually people's form gets worse the faster that they run. From a biomechanics standpoint, they just have worse proprioception and ability to know what they're doing as they're running faster, and so that they think they're running better because their ground contact time is less. But we're not advocating. Like, I think we're both saying, hey, modify the load. I'm going to back off of intensity first to give them a chance to try to get some of that down. Scott sounds like he might be more along the lines of like reduce total volume, not just intensity, or add recovery to their intensity, maybe cut intensity volume in half as opposed to eliminating it there. So, yeah.
Another thing to think about along the same as I'll call this number 3, but it's similar to modifying that is, change the terrain in which you run. So I'm a big proponent of maybe with these type of situations running uphill, right? Yeah. I like running uphill because you decrease the amount of torsion.
Load modification, I would still put that under load modification, and I was going to include like body weight support at the same point. So whether you're doing like there's AlterG, there's lever, there's light speed lift, there's boost treadmills, there's like lots of great options out there that people can use. And this is something that I do, and I've done with my professional runners a lot, is getting, if they do want to be running faster, they don't want to slow down and reduce some of the loads, and they want to increase, I'll put them on body weight support and have them run that way, because then they still get the neuromuscular feel of what it's like to run at that speed, but their forces are reduced. And I think, I don't know if this is the exact right to throw it in there, but an article I quote all the time is the Stuart Warden article. I think it was 2021 in JOSPT, that talked about if you reduce the stress on the bone by 10%, you can run twice as far before your structural capacity will be exceeded. So when we're talking about some of this stuff too, we're saying load modification, and then as we move into 3, 4, and 5, remember it doesn't have to be a monumental shift. It could be 10%, and that's going to let the person do twice as much as they were doing before they got injured. So a little bit goes a long way here.
Yeah, and I use the AlterG and the boost a lot with my athletes, right? It's part of our return to run progression with pretty much all of our injuries. And to your point, a little goes a long way. And like for me, I don't get them on the treadmill lower than 65 to 70% of their body weight. Anything lower than that to me is like they're floating, and it's kind of counterproductive.
It can change their form. Any more than 20% reduction changes their form.
100%.
And can have a little bit of negative impact. So why do too much? Unless it's like a pain thing. That the more than 20% is more like you're post-surgical, or you're getting somebody back from non-weight bearing, and it's like it's this or nothing type thing.
Right. And I'm a big fan just in general of, if you're a mileage kind of person and you need to get your mileage in, I'm a big fan of getting some of that mileage in on the AlterG, even if it's at 90%, of your body weight. Because again, like Doug just said, for those given reasons, taking an extra 15 to 20 miles of your weekly mileage out from the road and putting it at 90% is going to go a long way.
Yeah. Yep. All right. So you kind of already alluded to my number 3 and kind of grouped it in there together, but I'm going to say gait analysis is number 3. I think that's a huge part. I think one of the stories I always love to say is when I first started working with a lot of pro runners, I remember working with Drew Hunter, who we've had here on the podcast. And Drew used to tell me, it was kind of a funny introduction, and told me a lot about Drew. He's like, I feel like I have a JV high school injury because I just get shin splints all the time type thing. And when we did his gait analysis and we addressed some of his overstriding mechanics, he's never had that pain again. He told me, it's like, listen, I've had other injuries, I've had things like that, but as soon as we address that remove the stress from happening that causes it there, I think it really made a big difference. And there's countless other recreational runners that have had the same kind of experience, that when you evaluate a runner, if you address some of those common things, we talk about the run DNA categories with overstriding, collapsing, bouncing, weaving, glute amnesiac, like addressing that stuff does make a huge difference. So I think gait has to be part of it. I think that's a big missing piece that most people don't do, surprisingly, with medial tibial stress shortening, is actually look at the running. Mm-hmm. So, Scott, anything to add on that? Or
no, I'm right there with you. I'm right there with you with that. So
and that's
go ahead.
Like with the collapsing mechanics goes to what we were saying also with the axial torsional. It's not just the overstriding, because overstriding, it's physics, right? It's going to put stress on the body. It's the lever arm. It's going to put more stress on the body. There's braking forces. But collapsing, we're going to see this a lot too, where it is that like axial torsional kind of thing that's really putting some stress on the body there. So if you're seeing overstriding, if you're seeing collapsing, you got to address it. You got to do drills. You got to do all those things we teach in the courses. Like that's a big part of it. So don't forget that. And well, maybe I'll ask, like, at what point, because this is a question we get in the courses, Scott, all the time, right? So at what point would you look at their gait?
Depending on how irritated they are. And I'd probably try to get them on. I would definitely test them visit 1 and see where they're at. And if they're in too much pain or it hurts too much, or I see them notably limping, then obviously it's not going to tell me much. But I will try to get them on the treadmill day 1 and see what it looks like. And then if I can't get them on day 1, then we're going to try to do it, once we get the symptoms calmed down as soon as we possibly can. So I'm a big fan of, for a lot of reasons, not just, from the detective standpoint, but from a buy-in standpoint and all the other things that are associated with the psyche of a runner, getting them on the treadmill and evaluating how they run as an expert in running, I think is crucial for them to, have confidence in your ability to get them right.
Yeah. And they know that the goal is to get them back to what they want to do. That's important. So, all right, gait analysis. We talk lots about that in lots of other places. So we'll leave it at that for now. All right, next one. What are you thinking next? I got a number 4 here, but this is one I'm going to bait you a little bit and say this is one where you and I have got off on tangents on this, and something that maybe is a temporary use here, if I'm baiting you enough now.
You are. I wasn't sure if I should put it now or the next one, but I'll put it now just because you kind of threw it there. Don't be afraid to use orthotics.
Yeah.
Is
I
my
put this as like equipment modification.
Yeah.
So I would say like shoes and orthotics. This is one of the few times that I'm using orthotics mostly.
I use a lot more. But again, this is one of the reasons. So it's all about shifting load. And I'm going to get on my soapbox. One of the things that I like to preach on all my lectures and talks is just about stress versus capacity, and you increase your capacity and decrease stress sometimes by shifting loads to other regions that are better able to handle it. And orthotic in this case, especially if we're talking about somebody we believe is moving excessively or either excessively or too rapidly, or not rapidly enough, are ways in which we know we can manipulate how their foot contacts the ground. Now, we can debate all day long whether or not this is a long-term fix or not, but we do know, in my world specifically, that my job is to get my runners back as safely and as quickly as I possibly can, especially when you're dealing with high-end Division I athletes at the level I deal with. If I can get them back safely and quickly by implementing a piece of EVA foam or Plastizote or Subortholine in their shoe, which just shifts the load to a temporarily better, potentially, region of their body that can better handle it and take some of the load off of the tissue that needs to be deloaded, I'm absolutely going to do that 100 out of 100 times.
Yeah. Yep. And this is one, I agree with Scott here. Like it is something, it should be a tool in the toolbox. There can be simple ways of doing it. over-the-counter ones even can just shift enough load. We don't have to do a ton. I know on our like my clinic website, omegaprojectpt.com, we have like, hey, we just recommend some over-the-counter ones that people can pick up, so that, because they're always asking us, and we just link to it on our website. So we say, hey, go on the website and check it out. I think that having those kind of resources available and making it easy for your patients to do, I think, is also important. If you just say, hey, go by Walgreens and pick one up, they're going to go to Walgreens and find like 13 different varieties of orthotics, and they're going to go and be overwhelmed and not know what to do. So be their guide here and give them a little bit of guidance there.
These are my favorite. Again,
soles are great.
They're my favorite. And the reason I like them for the over-the-counter variety is just because of how easy it is to adapt things to the bottom, whether it be from an adhesive standpoint or a glue standpoint. They're heat moldable, so if I wanted to modify the arch, I could. If I wanted to reinforce the arch by putting something in here, whether it be some additional foam or felt, just to add some extra support to it, I can. They're relatively inexpensive in the $50 range, give or take. They make thin, they make wide. So if you've got a wide foot, they have it. If you've got a really thin foot or need to put it in a cleat or something, you can. So they have different ways in which you can kind of manipulate it based on the shoe you're putting it in. But to me, if you're just trying to go for a quick fix, not spend a whole lot of money, these are a great product. There are some other ones I don't like as much, just because of the bottom not being as smooth and not being able to take to glue as easily. So for me, somebody that likes to modify and play with things and do a little arts and crafts in the clinic, it's not as fun and not as it's not as easy. But these work really well. So I'm a big fan of these. I keep these around all the time. I use them myself because I think they're a great tool.
Yeah. Yep. All right. On to shoes, on to equipment modification. This is the thing that I can pretty much tell you the exact point at which my shoes wear out, because I will get a little bit of this medial tibial stress syndrome. And there is a shelf life to shoes. I think it's important to acknowledge their role in this, that you should be paying attention to this, keeping track of it, making sure that you're switching your shoes out appropriately. We know to use different types of shoes will help to shift the biomechanical stresses that your body is experiencing there. So not bad to have two entirely different pairs and rotate them, but make sure you're getting good shoes for that there. Scott, anything else on that? Or
yeah, I think there's a lot of different components of shoes you can look at. You can look at the actual stack height, which is the thickness of the shoe, how that plays into it. You can look at the heel height or the heel drop and how that plays into it. You can look at the actual just general weight of the shoe and how that plays into it. Are there any flares? So all of these components need to be evaluated. And this is, again, where you put your detective hat on and say, okay, how is this particular shoe potentially leading to a gait mechanic that is maybe suboptimal. And again, we know that certain shoes will lead to certain ways people run. People run differently in different shoes. Doug has probably seen that numerous times on his system just by looking at just changing shoes and how the numbers differ on the 3D system. It's amazing. So
we do a ton of that now, and it blows my mind. Like, I used to be of the persuasion, like, oh, your mechanics are your mechanics kind of thing. And then we started doing a bunch of like pre-post with different shoes on for people. And it's like, oh, wow, no, there's a big interaction of your shoe and how it affects your mechanics. And like we said, well, if 10% can make you be able to run twice as far, like what can 10% do in the wrong direction, right? They haven't done that study, so we can't definitively say it. But I mean, if you do, like, common sense wise, it would say, oh, well, if a shoe makes you 10% more stress on your body, it's definitely not a good thing.
The interesting thing is, people always say the most important thing and we saw this with my athletes at the college level is, what's the most important thing in picking a shoe, right? Comfort. Nobody will debate that. Comfort's the most important thing. Well, if you've only tried one shoe for the last 5 years and you kind of go back each and every year for the same shoe, you have no idea what shoe is more comfortable or less comfortable, right? So, oftentimes you will say, what, maybe it's your shoe. Have you tried a different shoe? No, this shoe has been good to me. Well, why don't you go to the shoe store and maybe try something in this variety and see how it feels. Like, if it just feels better, just try it. And you'll be amazed by how many people just get positive results from that. Yes.
Yeah. One other thing on the shoes before we move on to the next one, and I had a picture. This is like an old school picture I put up here, but basically, the way that you tie your shoes does make a big difference for medial tibial stress syndrome. And I put an example of this like butterfly lacing up here. And sorry for the quality of the picture. Obviously, if you're listening to it, you won't be able to see it. But if you go onto YouTube, you'll be able to see it here. But you basically take the lace and go from the second to last eye hole into the last eye hole and make a rabbit ear basically, and then you cross over so that the other lace goes through the rabbit hole on the other side, and then you pull the two laces forward and then cinch it back, and that kind of locks the shoe in position. I can't tell you, like, this was big for me when I was doing my triathlon because my shoes would come untied because I was just shaky coming into transition, and I would do a bad job tying my shoes, but they would never really come loose because of this. And it keeps your foot from really like sliding back and forth in the shoe, and it keeps a more stable position of the foot. So I'm a big fan of doing this, and this is something I teach all of my patients. If they have ever had any shin pain, I teach them how to do this.
I used to tie my shoes like that all the time, not even just for shin pain. I used to, because I felt like it was a good tight fit, right? I don't do it that way anymore. But no, I know that I agree with you. It really cinches that shoe to the heel. It really does.
All right. So what was the one that you were going to do before we said equipment modification here?
You got it. Again, you can pull this into 100 different ways, but you got to increase your tissue capacity. And that is via strengthening and whether I'm going to even group in some like light jumping and plyometrics for capacity training. So that's why I kind of said capacity as opposed to strengthening, because plyometric capacity is a little bit different too. So increase your tissue capacity around that region.
I agree. I had actually number 5 is like actually pain reduction, of getting the pain down quickly.
I think you can achieve that with all the other things, though. I think that's part of activity modification. I think that's in part of using an orthotic or a different shoe. I think that's in part due to changing your mechanics. Your goal in all of that is to try to find a situation in which you're experiencing less pain doing the activity. Because again, my role as a sports physical therapist is to get my athletes running. Even if they have a 2 or 3 out of 10 pain, I'm okay with that as long as it doesn't get bigger, higher, escalate, get worse the next day. So if I can find ways via all the things we mentioned previously to decrease their pain, doesn't have to go to 0, but to decrease their pain and make it more manageable and not escalate it, I'm going to do that. So that's why I didn't make a separate thing for pain.
So the reason I included it is a point that you made earlier about getting buy-in from the patient, that if you can come in and reduce their pain quickly, they're much more likely to do everything else you're going to ask them to do. They're going to be bought in with that. And I know modalities can be like a 4-letter word sometimes in this space, but I'm not opposed to doing it if it actually gets people like to get their pain down. I've used laser or technotherapy. I've done things like that have really been a pretty significant factor in getting people's pain down, so that we can analyze them and see what their actual movement patterns are like. They can do less training load modification and stay more with their sport. So I just wanted to bring up the point because I don't think it should be a stigma of, if you can do something like, there's good evidence now for a lot of these things. I mean, we're seeing laser and tech, like those tech, are like, we're seeing more and more articles to support some of those. And empirically from my own practice, I really do find that if I can get somebody's pain down quick, and if they're like, geez, I went to one visit with Doug and like my pain was 75% gone, then I have got their buy-in. And when I tell them to modify their gait, when I tell them to do strengthening, they're going to be all ears and they're going to do what I tell them to do. So I don't think it should be a stigma.
Yeah, no, I agree with you 100%. And I achieved that, like I said, via all the things we mentioned. I'll do like arch taping prior to orthotics for that same exact reason.
Yeah.
So it's just, we're in semantics here as to like how we kind of, is that its own separate category? Is it part of the other categories? To me, it's part of the other categories. If you want to, dial it out separately, it is obviously it's an important component, but but for me, it's a subcomponent of some of the other ones.
Of all the other ones. Yeah. And I think it's it's an intended, but it's just a consequence of doing some of the other things, like you said. Yeah. And good point about like tape the arch before you put an orthotic in. That's a good addition to what we were saying earlier. Just try them out with that first to give them the confidence of there. I do a lot of arch taping just to see if it helps out. I think that's made a big difference. So, and yeah, increased capacity. I agree. It has to be part of the equation. It has to start early. We need to make sure that people, like we said in the beginning, it's a high rate of reoccurrence for this injury. You have to have a plan, and it's not just like stretch your calf after you run. There needs to be a lot more comprehensive plan than what you'll find. And I think a lot of people will go on to Dr. Google and check out for these things, and they might look at like Instagram post or things like, but it really has to be a lot more comprehensive than that. So, all right. So far we have load modification, identify unique cause, gait analysis, equipment modification, capacity, pain reduction. We're doing better. We were at 11 for 5 last time. We're at like 6 or so now. So we're definitely doing better. So maybe anything else before we switch to like 3, I'll kind of share like 3 exercises I have my patients do. And obviously it's going to vary a lot based on the individual. But anything else about the actual like treatment strategies before we jump to the other stuff?
Recover. Make sure you're taking care of your body in the other ways. Sleeping, eating well, nutrition, all that stuff. Again, in everything we're going to talk about in these segments we do with the top 5 with Doug and Scott or whatever it is. Recovery's got to be a part of all of it, right? Nutrition's got to be a part of all of it. Building capacity is going to be a part of all of it. All of that is they're very, very common things that will keep you on the road running stronger, longer, healthier, and none of them should be neglected.
So maybe let's get a specific then, just before we move on, right? All right, you pick one thing that's top priority for increasing capacity for medial tibial stress syndrome.
Sleep. I think
What
to me,
about,
the
like,
most important part of increasing recovery.
I agree. It's the number one performance enhancing drug. But from an increasing capacity, it's increasing tissue capacity. If you were going to pick like an exercise or something, like what would be the number one focus for medial tibial stress syndrome for you? Would you do like soleus? What would you do?
I think you've got to look at the cause of why somebody is putting that torsional force through their tibia. So it's a combination of soleus, posterior tib, potentially glute med, quad. Yeah. All of those things have influence as to that torsional force that's going through. So I'm going to say, being a foot guy, I'm going to say make sure your tibialis posterior is doing what it should be doing.
Yeah. All right. Well, that goes into like starting with some of my exercises there. Like an exercise, like if I'm thinking 3 things that I just probably most commonly, again, we're going to preface this with it would be very tailored and individualized to the patient. It would be something that we really want to make sure is specific to what they need. But like a calf raise with a ball squeeze is a great way to start with it. I've got a picture of it up here with some instructions. This is like one of the exercises we have in the Run DNA app. There, I think that one's a great way just to kind of get a little activation. I don't know if we can call this like a true capacity type exercise there.
Couple it with blood flow restriction therapy, Doug. Couple it with some BFR cuffs.
Go. Put some BFR on that. Love it. Yeah. There we go.
Why not? Right? Because again, it's a low resistance type of activity other than your body weight. Now you can always make it a more resistive activity by adding a weighted vest, by putting a bar on your back, holding some kettlebells, whatever it may be. But if you don't want to do that and you just want to put the blood flow restriction cuffs on, I think it's another very, very good tool to have in your toolbox. Yeah.
Yep, I agree. All right, next one I have a video for, and I think I've got the audio, and I think it's going to cut us out, Scott, here, just FYI. But it's a weight-bearing ankle supination pronation exercise that I really like to do, and this would be great to do with BFR. It's also good to start adding like some load in your hands, and you can do lots of different variations with it. But here's another video, and I think it'll talk through it. So, that's just an exercise like if you couldn't see it, I was standing on one leg and I was just moving my opposite leg, my non-stance leg from so slightly to the lateral side, the outside of my leg, and then slightly to the back outside of my leg and go back and forth. And I like that one a lot just because it's nuanced actually, and it forces you to control a lot of the other segments as well. So, definition of kind of a closed kinetic chain exercise there. But, I do really like that exercise for getting some of that tibialis posterior, for working on some of those things too.
Yeah, there's a whole host. Whether I call them some matrix taps, where I'm reaching in the different directions of a matrix, or I'll do something called I call it a lunge with rotation. I tend to find my lunge with rotation really work more of the pronatus longus as it depresses the first ray. So I'll have them in a lunge position, holding a weighted ball, and I'll have them rotate to each side. And as they rotate and they start to lose their balance, their first ray really has to dig into the ground to kind of gain that support, and it really enforces that arch. So again, great tools to use, not using a whole lot of resistance there, right? You're using just your body weight, maybe a little bit of the ball to throw a little bit of momentum and whatnot into the equation. But again, I sometimes will throw a blood pressure cuff on that and do it with that type of activity to really just heighten the response a little bit.
Yeah. Yep. The other thing I give people is I have a specific warm-up that I have people do. And I, again, threw some pictures up here, and these are pictures, I took the top part off because I still had hair, and people would know how old these pictures are because there was, not a full head of hair, but some hair up on my head. But I have people do, toe walking and heel walking, and do it in 3 positions, with the feet facing forward, the feet facing away from each other, and the feet facing towards each other. And we do heel walking and toe walking. So you do about 20 feet of each of those, and you can do it once or twice. And I've found that that's a really good warm-up that makes a big difference for people if they're having pain on that beginning part of the run. That does make a big difference. I've seen people do backwards hill walking is another way to loosen up as well. I know that actually that's kind of popular now, backwards uphill walking. But those are just some ways that those 3 exercises of the calf raise with the ball between their heels, doing the weight-bearing supination and pronation, and doing the warm-up. I found, as a general rule of thumb, if somebody that I've never evaluated, a buddy from high school calls me up hey, I got shin splints. I hear you work with runners. What can you do? Those are some general things that I'll give people.
Mm-hmm. Good.
Scott, any other exercises or things that are your go-tos? I mean, ice massage is the only other thing. Sometimes for home, I'll talk about if they're really wanting to reduce pain. Voltaren gel is now an over-the-counter kind of thing. Sometimes that stuff can make a difference too, just to get pain down, so they can get back to
totally
activities.
Fine with that. Totally fine with that. Mm-hmm.
Yeah. So, all right. Well, hopefully Scott now is going to get on the medial tibial stress syndrome bandwagon, and if you're in the Gainesville, Florida area and you have medial tibial stress syndrome, please go and ask for Scott so that he can treat a ton of these.
Flood my patient load with medial tibial stress syndrome injuries. Yes. Can't wait.
All the shin plane, please go to Scott in Gainesville. You can see he's great at it, even though he doesn't like treating them. He's got a great approach to treating them.
And the funny thing is, somebody that treats pretty much 90% below the knee, and I see a lot of them. Maybe that's why I hate them so much, because I do see a lot of them. But yeah, fun stuff.
Yeah, that's fun. So, all right. Well, hopefully you guys are enjoying these 5 things with Scott and Doug. Love to hear what other things you want us to talk between 5 and 20 points about, depending on how long-winded we are that day. But thank you for listening to the Run DNA podcast. If you want to hear more kind of stuff, subscribe, and also check out the newsletter. Head over to rundna.com and sign up for the newsletter. We should have a link for it as well. But appreciate everyone listening, and hope you're having happy, healthy running. Thanks, Scott, for being on.
Absolutely.
Like what you hear? Leave a review of the show wherever you listen, and don't forget to subscribe so you never miss an episode. Run DNA helps runners and running specialists through education and technology to identify each runner's unique injury profile to avoid setbacks and maximize results. The Run DNA podcast is produced by Ace Running LLC. The Run DNA podcast is intended for educational purposes only. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can occur. Always seek the guidance of qualified medical professionals before making healthcare decisions. Find us online at rundna.com.